Hello everyone, in this lecture we are going to look at the general anatomy of the respiratory system as well as the histology. So the respiratory system is first structurally divided into two categories, the upper and the lower respiratory tract. Your upper respiratory tract consists of your nose, which is your nostrils and your nasal cavity, followed by the throat, which is the pharynx. We already know the three parts of the pharynx. Now, in the distal part of the pharynx, we have our voice box, which is known as the larynx, which also is part of your upper respiratory tract. The upper respiratory tract ends with the larynx, and the distal part of your trachea is where the lower respiratory tract begins. So here is the trachea, and posterior to the sternum is where your trachea splits into two. So here you're going to see two branches of the trachea, and each branch is called a bronchus. Together, they're called bronchi. So the lower respiratory system structurally consists of your distal trachea, two bronchi that further split into microscopic air holes called bronchioles, and those bronchioles go into air sacs that make up your lungs. So we have two lungs. This is the right lung and the left lung. So as far as we're talking about the structural anatomy, we're going to look at the nose, including the nasal cavity, part of which you've already gone over in your skull section of your skeletal system. Next, we have the pharynx, which we did part of it in your digestive system, followed by the larynx or the voice box. Then we have your trachea, which is your airway, and it's located on the anterior side of your esophagus, followed by two branches called bronchi, plural, or bronchus, singular. And those bronchi further split into smaller air tubes that further split into microscopic air tubes called bronchioles. And the bronchioles enter lung tissue, and lung tissue makes up the two lungs that we have, the right lung and the left lung. Now, functionally speaking, functionally refers to what is happening in that zone of your respiratory system. So the basic exchange of gases. So when we inhale atmosphere, we're inhaling all gases that make up Earth's atmosphere, not just oxygen. So all those gases that make up Earth's atmosphere are entering through our nose, then they're going into your throat, then they're entering your airway. So from the airway, they're going to go down the trachea, they're going to go down the bronchi, further split into the bronchioles, and then they're going to enter units of lung tissue called alveoli. So these like clusters of grape-looking structures that you see here, they're called alveoli. The plural is alveoli, singular is alveolus. So the gas exchange, the exchange of oxygen from Earth's atmosphere, from gas phase to our bloodstream, which is liquid phase, is happening inside your alveoli. Everything preceding that point, so as air enters your nose, your nasal cavity, it goes down your throat, your voice box, your airway, all of that is basically conducting air from point A, which is Earth's atmosphere, to point B, which is where respiratory gas exchange is actually happening. So everything alveolus and up, or lung and up, is the conducting zone, and alveoli itself is called your respiratory zone. And we're going to look at each section and further tease it apart. So next, let's look at the general structure of the respiratory tubes, right? So your airway, your nostrils, your throat, all of that is part of a tube. And just like we saw in our digestive system, our tube, or the walls of this tube, is going to have your mucosa, submucosa, and muscularis externa. So here, this slide is basically reviewing what the respiratory mucosa looks like. So I've marked this as self-study because most of this we've already gone over. The pattern of this remains the same. The type of epithelium here is going to differ, and I'm going to go over that part. So in the respiratory mucosa, which is that first layer of the wall of the tube that lines the respiratory lumen. Now, remember, in Earth's atmosphere, there's a mixture, and there's dust in the atmosphere. There could be airborne bacteria, viruses, chemicals, a lot of different types of things, right? So here, the bottom line is for oxygen and oxygen gas only to go from gas phase, which is Earth's atmosphere, and diffuse, become liquid phase, and actually enter your bloodstream. So structure follows function. In the upper respiratory tract, you are going to see ciliated, pseudostratified columnar epithelium. Now it's ciliated because cilia move or beat outwards, and they work to trap any kind of debris, bacteria, or whatever's in Earth's atmosphere that shouldn't be going into your lungs is basically caught by the cilia and the hair in your nasal cavities. So cilia beat outwards, and they help keep junk out of your lower respiratory tract. And as you go down from the upper respiratory tract down to the alveolus, which is the lower respiratory, like the point where oxygen is going to be in its gas phase last, this epithelium becomes progressively thinner. Because as you get into the lung, so oxygen gas, which is basically O2, has to diffuse through this epithelium. It has to go pass through your cells and enter your bloodstream. So if it was fairly thick, then diffusion of oxygen across this membrane or epithelial tissue would become difficult. So up in your nose and nasal cavity and throat, we basically have, and trachea is pseudostratified ciliated columnar epithelium. You will also see an abundance of goblet cells that secrete mucus, and mucus keeps your upper airway or upper respiratory tract lubricated and prevents drying, because Earth's atmosphere also tends to be pretty dry. Now, as you go down the bronchi, right? So here's the main bronchi. The main bronchi are where your trachea split into two. The bronchi are further going to split into lobar bronchi, or branches of the main ones, and these go into the lobes of your lung. So think of lobes of lung, lobar bronchi. Now, past that, they become even smaller branches. They become segmentals, or tertiary bronchi. So here, it becomes a simple ciliated columnar epithelium as opposed to simple or pseudostratified columnar epithelium. Now, as you go farther down and the air tubes become microscopic, so the difference between bronchi and bronchioles is that bronchi are macroscopic air tubules versus bronchioles are microscopic air tubules. So as you go down to the microscopic ones, they become a simple ciliated cuboidal epithelium. So here, as you're going down from the upper to the lower respiratory tract, the point of the epithelium is to get thinner and thinner and thinner. So it's easier for oxygen gas to be able to diffuse from gas phase to liquid phase. To the point where as you get into your alveoli, which are those grape-like nodules inside of your lungs, the tissue there is going to be simple squamous epithelium. Now it's simple squamous epithelium because it forms like the thinnest barrier for oxygen gas to pass through. And as we get through to the physiology of this chapter, we're going to look at this even more. Now, respiratory mucosa is rich in goblet cells. Now, goblet cells are secreting your mucus, which prevents drying of your tissues. It has mild antimicrobial properties. And so the protein mucin is what makes mucus slightly viscous. So it's not watery. There's a bit of sort of like jello-like, a mild viscosity to this mucus. And this helps to trap a bunch of dust, dirt, dander, pollen, and anything that should basically be prevented from entering your lower respiratory tract. Now, mucus, a healthy mucus, also contains some antimicrobials. So lysozyme is your enzyme that is secreted by the lysosomes of each cells. And this is the same stuff that the Paneth cells in your Peyer's patches secreted in your digestive system. So this lysozyme is present in mucus, and mucus does have an antimicrobial effect. It also has proteins called defensins and something called immunoglobulin A. So immunoglobulins are proteins that are present in blood, and they're basically something called antibodies. So anything that is foreign, so for example, dust or pollen are considered foreign objects or foreign molecules by your body. So when a foreign molecule enters your body or makes contact with your body, your immune system can produce molecules known as antibodies in response to those foreign molecules. And out of all the types of antibodies that the body makes, immunoglobulin A, which is one of the more generic types of immunoglobulins, is present in mucus. Now, a lot of times we notice, especially clinically, is that when there's an overproduction of mucus or it becomes hardened and it catches all kinds of dust, debris, and it becomes thick in your airway, that is referred to as sputum. And sputum in of itself is not dangerous, but if sputum starts appearing like discolored to be yellow or has a green tint to it, that could potentially be a sign of infection. So this is parts of your upper respiratory tract. I've marked it as self-study because all of this was basically done in your skeletal system when we kind of looked at the skull and facial bones, and the three subdivisions of the pharynx were also covered in your digestive system. Now here's where I want to, what you're looking at is a mid-sagittal section in this diagram, a mid-sagittal section medial view. So right here, this green shaded region is your nostril. So these are the openings right at the tip of your nose. So nostrils is where air enters into your body from. From the nostrils, it's going to go in this blue shaded region, which is essentially the nasal cavity, right? So here, what you're looking at is these three structures, structure 1, structure 2, and up here is structure 3. And those are basically your nasal conchae, also known as nasal turbinates. So here's your superior nasal concha, middle nasal concha, and inferior nasal concha. And in this image, they're basically just covered by skin and soft tissue. Now, right up here, your superior nasal concha is actually part of your ethmoid bone. So what you're looking at right over here is your cribriform plate of the ethmoid bone, and this is where your olfactory bulb, which is cranial nerve number 1, is going to sit right over here. This little hollow here is your frontal sinus. This is the sphenoidal sinus. This orange shaded region here is your pharynx. This is the uvula, and here's your oral cavity followed by the tongue. Now this little gap between your sphenoid bone, the soft palate, this little archway or gateway into your throat is also referred to as a choana. So choana is basically the gateway between your nasal conchae and your throat. Now this diagram here, diagram number 2, is a cadaver dissection. This is a frontal cut as it appears here, superior view. So these two cutouts right here is normally like where your frontal bone, your frontal sinuses would be. Here's your orbit right here. Here, let me change this to red. So here's your inferior nasal concha, here's the middle nasal concha, and this teeny tiny little guy up here, that's your superior nasal concha. Now this structure here that I'm shading on in green is the perpendicular plate of your ethmoid bone, which forms the superior part of your nasal septum. In purple, I'm going to shade the bottom part of your nasal septum, which is the vomer. It's that guy right there. Now these two hollows are your maxillary sinuses right over here. So the paranasal sinuses too were covered when we did the skull. So I have marked this slide as self-study. Followed by the throat. So you already know that the throat is classified into 3 categories. The superior most one is the nasopharynx, followed by the area posterior to your uvula, which is the oropharynx, followed by the most inferior segment right here that sits right on top of your larynx is your laryngopharynx. Now the nasopharynx is something that we did not cover as part of your digestive system, and it is posterior to the nasal cavity itself. So think about the area behind your nasal cavity, so behind your nasal septum. The epithelium there is pseudostratified ciliated columnar epithelium with an abundance of goblet cells. Now back from your A&P1 when you did the ear anatomy, in your middle ear there was a tube that connected your middle ear all the way to the back of your throat. That tube was called the eustachian tube, also known as the auditory tube. So this was like the pressure gauge or the pressure valve. This is what pops when you are either changing in altitude or the pressure changes, you feel your ear pops. It's the eustachian tube that is popping. Now the nasopharynx also contains one of the types of tonsils, which is the pharyngeal tonsil. So tonsils are essentially sort of lumps or clusters of lymphatic tissues, and they work as air sieves. So they're catching stuff from the air, and they release infection-fighting cells and proteins. We're going to talk about those when we go into your blood, your hematology unit. Now, the one tonsil, the large tonsil that is present specifically in your nasopharynx, is called the adenoid. So the adenoid is right where the eustachian tube actually joins the nasopharynx. So in kids that have ear infections fairly commonly, sometimes it's their adenoid that swells up and is blocking the drainage from the eustachian tube from being drained into the throat. And the fix for that is typically an adenoidectomy, is to go in and remove the adenoids to unblock that sort of pore so that the eustachian tube can drain stuff into the throat again. The oropharynx is behind the uvula. And this is a common area to both food and air. And this too has a ciliated, stratified, columnar epithelium. So ciliated, pseudostratified columnar epithelium. Now these have the palatine tonsils on the lateral wall. So if you stick out your tongue and open your mouth really wide, you see these tonsils that are on either sides of your uvula. Those are your palatine tonsils. We also have a tonsil called the lingual tonsil at the base of the tongue. And tonsils collectively are lymphatic clusters of lymphatic tissues that are trapping foreign bodies, dander, pollen, pathogens like viruses, bacteria. So tonsillitis is inflammation of the tonsils, and tonsillectomy is a common youth surgery. So the laryngopharynx, the star structure of the laryngopharynx is going to be your larynx, and we're going to talk about what that larynx is in a fair amount of detail. It is lined by non-keratinized, stratified squamous epithelium. So this is a review of the pharynx. Here you are seeing the eustachian tube coming and attaching your nasopharynx right here. And here is your pharyngeal tonsil, also known as the adenoid. So if the adenoid swells up, it tends to block off this opening of your eustachian or your auditory tube. So this is your oropharynx, followed by the laryngopharynx right here. And the laryngopharynx is where there is an opening of your larynx anteriorly and your esophagus posteriorly. So let's go over the detailed structure of the larynx. Very, very important. So starting with the anterior view, let's start off with something that you already know. This horseshoe-like bone that sits right inferior to your mandible. So this right here is your hyoid bone. So the larynx itself has a few major cartilages. Well, let's review what those cartilages are. Anteriorly, this cartilage right here is called the thyroid cartilage. So number one is thyroid cartilage. Over here you have a prominence, the laryngeal prominence, which is more prominent in males. And the structure number two, that is what is commonly referred to as the Adam's apple. So number one is the thyroid cartilage. Number two is the laryngeal prominence. This cartilage right here, this ring-like cartilage, number 3, is known as the cricoid cartilage. Now, the thyroid cartilage is attached to the hyoid bone with this membrane called the thyrohyoid membrane. Now, beneath the cricoid cartilage, which is number 3, the whole trachea is anteriorly supported by C-shaped cartilaginous rings. So these are made up of hyaline cartilage. You already know what hyaline cartilage is. And they're not perfectly circular. So there's cartilage in the front, but if you look at the posterior view, these rings are C-shaped and not O-shaped. So over here is where your trachealis muscle would sit. So right here, the one that I'm shading on right now, is where you would see the trachealis muscle. So a review is, this is the hyoid bone. Number 1 is your thyroid cartilage. Number 2 is the laryngeal prominence, also known as the Adam's apple. Number 3 is the cricoid cartilage. And beneath the cricoid cartilage are stacked C-shaped cartilaginous rings that are made up of hyaline cartilage. So let's flip over and now look at the posterior view. Posteriorly, you are still seeing this, which is the hyoid bone. Now this giant hood-like flap, this is the epiglottis. You can see part of it sticking up from the anterior view as well. So this over here, structure number 4, is the epiglottis. So the epiglottis is like a flap that temporarily covers or closes your larynx as deglutition or swallowing is happening. So that is your epiglottis. Now over here in the back view, you are looking at 2 additional cartilages. So this right here is still your thyroid cartilage. You are seeing this back view of your cricoid cartilage here. So this is still structure number 1, your thyroid cartilage. This is still structure number 3, your cricoid cartilage. Now the 2 other cartilages are small and look like fangs. So this guy right here, it is bilateral. So those 2 right there are called arytenoid cartilages. Arytenoid cartilages. And we're going to see what, they're basically attachment points for your vocal cords. Sitting on the superior side of the arytenoid cartilages, let me change the color to say green, are teeny tiny cartilages right here. Those. Also bilateral, those are corniculate cartilages. So you have the inferior one, which is the arytenoid cartilage. You have the superior ones that sit on top of the arytenoids are the corniculate cartilages. The last cartilage here is even tinier, and it's on the superior and lateral sides of the corniculates, and that is the cuneiform cartilage. Cuneiform cartilage. So if we were to, in an oblique view, review all of the cartilages, this is number 1, your thyroid cartilage. This is number 2, the cricoid cartilage. This is number 3, the arytenoid cartilage. Number 4, the corniculate cartilage. And finally, the little one, which is the cuneiform cartilage. And this is where your trachealis muscle would be, and the anterior side of the trachea is supported by C-shaped hyaline cartilage rings. Now, most of this I'd like you guys to read on your own, but I'm going to explain this on the next slide. So put a star mark here. I forgot to add in the self-study. I'm going to explain this. I'm going to explain this just based on the image that's coming in the next slide. So these are superior views. You're looking at the top down the barrel of the trachea, right? So you're looking at the voice box or the larynx superiorly. So let's review the cartilages here. In both of them, this is your thyroid cartilage. This one is your cricoid cartilage. These ones is your arytenoid cartilage with the corniculate cartilage sitting on top. And in both the diagrams. What you are not seeing here is the cuneiform cartilage. The next structures we're looking at here are these two cartilage and ligament-based structures, your vocal folds or your vocal cords. They are structures that look like little curtains. Now in image 1, this is a vocal cord or a vocal ligament, and this is a vocal ligament. Now here, it is in adducted. So adduction is to bring something closer to the median, right? So the two vocal cords are adducted or closed right here. If you look at the next diagram here, the vocal cords have moved away from the median, and so they are abducted. Now, a laryngoscope is basically a tube with a light and a camera on top, and we will look at a live laryngoscopy video in class. So this is basically what you saw in the previous slide, the cartilaginous structures, except here it is covered with soft tissue. So this is the back of your tongue, the base of your tongue. This flap you're looking at is your epiglottis. These structures, the lightly shaded lines, are your vocal folds or vocal cords. And there's a curtain of tissue right here that is called the vestibular fold. Now, vestibular fold is like a curtain on both sides. When your cords are adducted, the curtain is pulled shut. When your cords get abducted, the curtain opens. So abduction is opening of the vestibular folds or curtains. Adduction is closing of the vestibular folds or the curtains. You're also seeing your other two cartilages. You're not seeing the arytenoid. You are seeing the corniculate cartilages right here, followed by the tiniest of cartilages, which is the cuneiform cartilages. Now moving on to the trachea. So the trachea sits anterior to your esophagus. So if this is your esophagus, the trachea sits anterior. So here is your thyroid cartilage, here's your cricoid cartilage. These are your hyaline cartilage C-rings anteriorly. So if we were to take a transverse cut and look into the barrel or the lumen of the trachea, this is the lumen, lomag, lumen of the trachea. Right here in the back is your trachealis muscle. On the anterior side are your cartilage, your hyaline cartilage rings. Please note that your trachea is still a mucous surface, so it has that ciliated pseudostratified columnar epithelium. Now this kind of like floppy lumen in the back is the lumen of the esophagus. Remember that your trachea is constantly kept open by your C-rings, and a blockage of the trachea can be fatal really quickly. So here's a fresh cadaver dissection. You're looking at the trachea and these clear sort of whitish rings that you're seeing right here are your hyaline cartilage C-rings. Now right here is where the trachea splits into two, and each is called a main or a primary bronchus. Now this region where it actually splits, the point of bifurcation, is called carina with a C. This is your right main bronchus or right primary bronchus. This is your left main bronchus. Now the tracheal wall, you have your epithelium, which is pseudostratified ciliated columnar epithelium. There's going to be goblet cells here that secrete mucus. You're going to have your muscularis mucosae to squeeze out the mucus into the lumen. Your submucosa is also here, and you can see the lumens of the vasculature right here. Now, the submucosa is right here. Submucosa right there, followed by the C-ring of the tracheal cartilage, which is basically hyaline cartilage. Now let's look at the different branches of each primary bronchus. So here's the trachea, here's the carina. This is your right primary bronchus. This is the left primary bronchus. As it enters into the lung, it splits into branches first, called either the lobar, going into each lobe of the lung, or secondary bronchi. So these are your primary bronchi. Further branches of them are your secondary bronchi. They further split into segmental bronchi, called the tertiary bronchi. Now these branch further, and here's where they start to become microscopic. So microscopic air tubules are now called bronchioles. So the only difference between bronchi and bronchioles is that bronchioles are microscopic. Now here's the chronology of the bronchiole. The tertiary bronchi, or the segmental bronchi, branch into smaller bronchi. The smaller bronchi branch into bronchioles. Bronchioles branch into something called terminal bronchioles. From the terminal bronchioles, they become smaller, called respiratory bronchioles, and then they become teeny tiny, which is when they're called alveolar ducts, and this is where they open into these nodular sacs called the alveoli. Now the diameter of these tubules, both bronchi and bronchioles, can vary. When the diameter decreases, it is called bronchoconstriction. When the diameter increases, it is called bronchodilation. Too much bronchoconstriction can obstruct the airway and can cause hypoxia, which is lack of oxygen in your tissues. So what you want is your bronchi to be nice and dilated so that the air can actually enter through the trachea, through your primary or your main bronchi, unobstructed, go through your lobar or secondary bronchi, followed by the tertiary or the segmentals. From the segmentals, they're gonna split into the bronchioles, the terminal bronchiole, and the respiratory bronchiole, followed by the alveolar duct, and get dumped into air sacs called the alveoli itself. So alveolar ducts lead to alveoli. Alveoli are essentially air sacs. They have the thinnest epithelium, and this is where gas exchange. So respiratory bronchioles are basically lined with simple cuboidal epithelium, but when you get into the sac itself, which is the alveoli, it is simple squamous epithelium, the thinnest one possible, so that oxygen can diffuse from gas phase to liquid phase into your blood, and carbon dioxide can go from liquid phase, which is in your blood, to gas phase, and that is how it gets exhaled out. So here's where you're looking at a zoomed in image of your bronchioles and alveoli with added vasculature, right? So this is a bronchiole right here, your microscopic airway. From the bronchioles, it becomes the terminal bronchiole. From terminal, it becomes a smaller branch called the respiratory bronchiole. From the respiratory bronchiole, it becomes this even smaller branch called the alveolar duct. And these nodular sacs are actually hollow on the inside. Now, if we palpate human lungs, which we will get to do when we go into the cadaver lab, the lungs are actually elastic and spongy. So they have to expand and contract many, many times during the day. So that the alveoli on the outside, the exterior side, have elastic fibers that allow them to change their size and expand and contract. In addition to that, all your alveolar sacs are covered or are richly vascularized on the outside. So you're looking at a bunch of blood capillaries, both arterioles and venules, which are the reds and blues here respectively. So let's make one thing clear here. So oxygen gas, which is O2, is going to go from gas to liquid and enter the red blood capillaries. From your various tissues, carbon dioxide is brought back from the venules, which is the blue. And from here, carbon dioxide goes from liquid phase to gas phase, and it is exhaled out. Now, inside the alveoli, I'm going to explain this slide on the next one where the diagrams are. So here's where the diagrams are. The two previous slides can be self-study. Now here you're looking at a zoomed in illustration of the inside of the alveolar sacs. So this is the hollow of the alveolar sacs. The most abundant cells you're seeing here are your simple squamous cells, the flat ones. So the most abundant cells here are the simple squamous cells, are actually called alveolar type 1 cells. They're your simple squamous epithelial cells. The next cell is a cuboidal cell. These are scattered throughout the alveolar sacs. They're not tightly packed, but every now and then you will notice that there's a cuboidal cell here and there. So this is an example of one. These orange ones are examples of simple cuboidal cells. Those are called alveolar type 2 cells. And these alveolar type 2 cells are going to secrete a substance called surfactant. And surfactant is basically watery, right? It's a watery material. It's not viscous like mucus. It's very watery. And it's preventing your air sacs from drying out, and it's actually helping your lung do its job. So type 1 cells are your simple squamous cells. Type 2 cells are simple cuboidal cells. In addition, you're going to have the junk-eating cells here, which are the amoeba-like cells. Those are your alveolar macrophages. So if you look at this diagram here, here's what's going to happen. So this is your alveolar type 1 cell, which is your simple squamous cell. This is your blood capillary right here. The blood capillaries are also lined with simple squamous cells called endothelium. This is your alveolar hollow, or your alveolus. So oxygen is going to diffuse from here through the wall through your type 1 alveolar cell, through the basement membrane or the endothelium. It's going to go into your blood and into your red blood cell. Carbon dioxide is going to go the opposite way. It's going to come back from your blood. It's going to have to diffuse out of your endothelium into your respiratory membrane, turn into gas phase, and be exhaled out of the lung. Now, the surfactant is important because it allows oxygen to diffuse into your bloodstream easier. So a lung without surfactant will have a harder time sucking the oxygen into your bloodstream. A lung with surfactant will have an easier time for oxygen to go from gas phase to liquid phase. Next, we're going to go over the anatomy of the lung itself. We have two lungs. We have a right lung and left lung. And they're sitting in cavities within your thoracic cavity. The exclusive lung cavity is called the pleural cavity, and I'm going to go over that next. So the lungs are sort of like conical in shape, right? And the difference between the right lung and the left lung is that the right lung has 3 lobes and the left lung has 2 lobes. So this is the superior lobe, middle lobe, and inferior lobe of your right lung. The left lung only has the superior and inferior. Now, the junction between the superior lobe and the middle lobe is called the horizontal fissure. It's not perfectly horizontal, but it's called the horizontal fissure. The junction between the middle and the inferior lobe on the right lung is called the oblique fissure. In your left lung, the junction between the 2 lobes is your oblique lobe, or your oblique fissure. Now, this is the apex of each lung, followed by the base of each lung. This is the lateral surface. This is the medial surface. You will notice that on the left lung only, the medial surface has like a C-shaped notch. This is because the heart is slightly positioned towards the left. This notch is where the heart would like fit into. So this notch right here on the left lung only is called the cardiac notch. Cardiac notch. And this little portion, let me change the color to green. This little portion inferior to cardiac notch and the base right here, that is called the lingula. Lingula. Now you're looking at the medial view. So you're noticing 3 tubes here entering and exiting your lung, right? There's a red tube, a blue tube, and a white tube. So the white tube here is the air tube, and that is your right and left primary bronchi, respectively. So right bronchus on the right lung, left bronchus on the left lung. Now the blue tube here and the red tube here. Normally, you know that if it's red, it's an artery, and arteries carry oxygenated blood. And if it's blue, it's a vein, and it carries deoxygenated blood. We want to move away from that assumption, right? Now here, if you notice, the red tubes are your pulmonary veins. Here is why. A vein is something that carries blood inwards towards the heart. So a vein is where blood is flowing in the direction towards the heart. An artery is a tube in which blood is going out, or the direction of flow is heart outwards. So here, the blue tube is your pulmonary artery. The red tube is the pulmonary vein. Now, the pulmonary vein is where oxygen is going to enter, and the blood is going to go from your pulmonary vein right to the heart. The heart pumps it all over the body to all of the tissues in the body, all tissues. So tissues are going to use that oxygen to perform Krebs cycle and synthesize your ATP, right? And a byproduct of Krebs cycle is carbon dioxide. So carbon dioxide is going to get into your systemic veins, and it's going to go back into the heart. And from the heart, it goes out from pulmonary arteries, because it's heart out, even though it is deoxygenated blood. So the blue tube that you're seeing here is the pulmonary artery. The red tubes that you're seeing here are the pulmonary veins. So this slide is, again, we're going to make it self-study because everything is clearly labeled. And I'm going to end with this slide right here, where you are looking at the heart and the lung. So here's the diaphragm. Here's your right lung, left lung. This is the heart right here. And in the heart, you have the top two chambers are your atria. The bottom two chambers are your ventricles. The right side of your heart contains deoxygenated blood. The left side of your heart contains oxygenated blood. So let's start with your pulmonary veins. The pulmonary veins are going to carry fresh oxygen from the lungs and into your left atrium right here. Fresh oxygen. From the right atrium, this freshly oxygenated blood is going to go into the left ventricle. And from the left ventricle, it is going to go all over your body. Meanwhile, deoxygenated blood comes back from the rest of your body, gets dumped into your right atrium. From the right atrium, it goes into your right ventricle, and from the right ventricle, it is going to exit through some arches here that we will deal with in Unit 3, but the tubes that carry this deoxygenated blood back to the lung are the pulmonary arteries. So the blue lines you're seeing here are the pulmonary arteries. The red lines you're seeing here are the pulmonary veins. Now, the last part is your pleural cavity. The pleural cavity is enclosed by two membranes. The one on the inside or deep is visceral pleura. The more superficial one is the parietal pleura. And there's pleural fluid that fills up the gap between your visceral and parietal. Now this liquid forms like a shock absorption, and it absorbs some of that shock of lung expansion with inhalation and lung contraction with exhalation that I will continue on in your next lecture.